Now, beginning with the session, a very warm welcome to everyone to the third session of this webinar series, which is titled as the Community Health Workers, Frontiers of Thinking and Evidence. These webinar series are hosted by OPM, Oxford Policy Management, and Women in Global Health India. These series aim to share evidence on CHWs and to actually discuss the areas around CHW empowerment, the enablers of performance of the community health workers, and complexities within which they function. In these series, we have tried to engage stakeholders from across the board so as to really reflect on the key concerns from different perspectives of researchers, of CHWs, and the health systems practitioners themselves. We essentially started the webinar series in the month of November with the first session where the question that we began with was, how can a CHW feel empowered? And through our discussions, that led to us to understand that CHWs are empowered and intrinsically motivated women who navigate within the constraints of health systems and the communities. And thus, we need to actually build enabling ecosystems for them to be able to deliver primary health services. While the second session in December brought out the complexities within which CHWs function in the communities. While we do acknowledge that they are empowered and these women are capable of delivering health services, they also come from the context in which they function. And hence their rights needs to be protected as they function within the complexities of gender and their social position given to caste as well. So that's in addition to providing a CHW-centered policy, it is important to build social accountability mechanisms where the formal system is responsive to the people it serves. So now that has brought to the next conversation around how do we leverage technology for transforming CHW's work? And with the mHealth technologies being used extensively and which was reiterated during the pandemic as well, for as job aids, as training delivery, etc. So we are glad to bring you the third session on this subject. We have Dr. John Oman from George Institute of Health as our moderator for today's session. And he's a physician, researcher, and a digital health expert. He leads the evaluation team on digital health at George Institute. So thank you, George. Sir, thank you, Dr. John. We move to you to begin the session. Thank you.
Thank you so much for having us here. And it's an honor and privilege to be discussing about the digital health interventions and how they are powerful tools for community health workers. Can I have the slides, please? So when we're talking about community health workers, we just want to set the context of which are the cadres and what are the primary functions that they do. So as we know, they comprise of the accredited social health activists, or the ASHA worker as they are called. And as you can see, they are primarily the first point of contact between the communities where people live and the health systems. So in terms of their activities, key activities comprise of making home visits on behalf of the health system, attending the village health and nutrition days, and facilitating visits to the health facilities as well as visits to the health facilities, maintaining records. And you would see in the latter part of today's conversation how crucial some of these digital tools are in their hands, and how can we use these tools to empower them further. And they are primarily also responsible for holding these interaction meetings at the village level. Next slide, please. The other cadre who are again in the community, closely living with the people in the community, are the Anganwadi workers. They come under a different Ministry of Women and Child Development, and they primarily responsible for implementing a program called the Integrated Child Development Service. And They look after the supplementary nutrition aspects, preschool education, health and nutrition education. They facilitate in immunization, as well as facilitating health checkups, as well as referral services. Next slide, please. And then we have the ANMs, or auxiliary nurse midwives. And as you can see, they have a number of responsibilities. And this is a screenshot of a digital tool that they use for their workflows. And they are primarily responsible for delivering services at the subcenter. And they are also responsible for looking after the population in a defined village or area. They are responsible for the service delivery in that area. And they are primary supervisors of the frontline workers, which are accredited social health activists. And they tend to maintain all of the records, which is beneficiary wise, or they also supervise most of the work and the data that the ASHA workers interact with. Besides this, they have a number of very important roles for the vertical program deliveries in the country, such as high risk pregnant women tracking, or low birth weight tracking. So they are the ones who are really holding the fort, as it were, on the front lines of health service delivery in the Indian context. Next slide, please. When we're talking about digital health intervention, we also need to know about the framework that we're going to be using. So for this conversation today, we are going to refer to the WHO digital health interventions classification, as well as the guideline framework for health system strengthening using digital health interventions. And these classifications have kind of grouped all the digital interventions into a couple of buckets, such as the ones that face the populations or people who avail of the services as clients, those that engage the healthcare providers as the healthcare provider bucket, and for health systems managers, people who supervise, who look at data, and of course, additionally, data services. Next slide, please. So I will just want to set a context. This is not set in stone, but from where we work at the George Institute, we've looked at both the WHO guideline framework as well as some evidence around use of digital tools. So here I'm going to use mHealth and digital broadly. And so what are the key factors or key consideration that we should keep in mind for today's conversation? So digital tools are very powerful in terms of enabling consultations or facilitating consultations and counseling. And frontline health workers or community health workers should actually use these tools and they can use it to counsel and influence patients' behavior in a positive way. We will hear about examples of that. And training the health workers, the frontline health workers themselves, is a job in itself. And how can we use digital tools to empower them through both their training for use of the digital tools as well as for all of their functions? Next slide, please. So one of the key aspects that when we use digital or mobile tools is to actually reduce the amount of workload, in one sense, the travel time, and particularly some of the coordination that could be actually done very effectively using digital tools. Are we doing that or not is something that we could understand from today's conversations. And of course, like any other tool, a tool is just an enabler. We have to have good frameworks to ensure the patient information confidentiality, privacy, and how do we really educate our frontline healthcare workers to be able to do this in a manner in which they don't compromise confidentiality or privacy, at the same time securing themselves in being able to follow best practices in terms of consent, data protection, storage, and ensuring their own credentials as well. Next slide, please. So, like we know, nothing can exist in a silo. So therefore, all of digital tools that we are talking about in today's context has to be at the core of the strengthening the health system, and it should be an integral component of health information systems that are there in the health services delivery. And we look forward to an exciting conversation this evening around this from experts across the globe and from within our country, people who are on the ground implementing, making decisions, as well as people who are academic researchers who have been evaluating the success, as well as some of the uh, potential areas for improvement, scale up, as well as for impact. So I would like to introduce, next slide please, Narendra Sinha, who is a state consultant with Ayushman Bharat at the National Health Mission Chhattisgarh. Narendra ji is a postgraduate in public health with specialization in epidemiology. He has worked extensively at district and state levels in Bhopal, Telangana, and Chattisgarh across various projects by AIMS, PHFI, UNICEF, and the Ministry of Health and Family Welfare. He is currently working as a state consultant, Ayushman Bharat, at the National Health Mission in Chattisgarh. Next, we have Rasmi Avulia, who is a research fellow at the International Food Policy Research Institute in Poverty, Health, and Nutrition Division. She primarily conducts implementation research focused on system strengthening to improve coverage of maternal and child nutrition intervention. She has a PhD in health promotion, education, and behavior from the University of South Carolina, Columbia, United States, and has conducted extensive research in India, Bangladesh, and the United States. We have Sarah with us. Give me a minute. We have Sarah Chamberlain, who is digital director for BBC Media Action in India, where she is responsible for designing and scaling mobile services for low literate, low-income communities. She has been at the forefront of digital communications in development sector for 23 years, including 13 years spent in designing and scaling mobile services in Asia. Her digital solutions have benefited millions of people and won many awards, which we will hear about shortly. I would also like to introduce Amnesty, who is an associate professor at the University of Cape Town, who specializes in evaluation of digital health solutions in low and middle income countries. Most recently, she has helmed teams assessing the reach and impact of large-scale maternal mobile messaging programs in India, Ghana, and South Africa. And she's been working very closely with the NHSRC and leading a whole range of research as well as collating evidence around digital interventions in the frontline healthcare delivery space. I would like to welcome all of our esteemed panelists for today's conversation and would like to now invite Dr. Narendra ji to give an overview of digital interventions in the context of a state of Chhattisgarh. So, Narendra ji, you've been working with the health systems across different contexts, and at the moment you are a nodal officer for implementing the health and wellness program. And could you please share some reflections on the digital intervention used for healthcare workers for population level health information? What is the role of community health workers in implementing these interventions? And how has these interventions helped community health workers in effectively managing their work?
Sorry to interrupt, Dr. John. Narendra is stuck in a meeting and he might join a bit late, so maybe we can move on.
Sure.
With Rasmi.
Sorry for that. Sorry for that. I was hoping he would join us, and apologies for that. I would request Rasmi ji to come in, and could you, based on your experience, share some of the observations from your own experience of actually evaluating the platforms, such as the CAS platform in both the state of Bihar and Madhya Pradesh, and reflect on the use benefits of these interventions. And maybe you could also speak into the context that we were initially hoping Narendra ji will give, and so then set the conversation going.
Thank you, Minji, and good afternoon to everyone. And thank you to colleagues at OPM and WGHI for organizing this panel and inviting me to be part of it. So before I jump into talking about what we found when we were looking at integration of a technology into the Integrated Child Development Services program, I would just take a minute to explain what the technology itself was. Next slide, please. Next slide, please. So the mobile technology that was introduced, piloted into the ICDS system, this was introduced in 2017, and it has three primary components. One is the app for mobile-based application for Anganwadi workers, who are the primary frontline workers of the ICDS system, who provide different services that Dr. John mentioned earlier. And this particular app digitizes 10 of the 11 registers that the Anganwadi workers use to keep records of their service delivery. And then there is another mobile-based app for their immediate supervisors, which provides the supervisors with the application to monitor the Anganwadi workers who work under them. And then there is a web-based application, which is the dashboard for the staff from the block, district, state to the national level, for these staff to look at what the service delivery itself. So this is a real time as the Anganwadi workers enter the data that would get consolidated into the servers, and then that can be displayed into the dashboard. So this was the primary application. And we were part of, for this multi-component intervention, we had a complex multi-component evaluation also set up. And this was conducted in collaboration with partners from UC Berkeley, UCSF, Nirman, Accountability Initiative, and there were several aspects to the evaluation itself. And I will be speaking primarily about the process assessment that we have taken up to understand how the rollout of the technology integration happened and how was it taken up. Next slide, please. If you could hit enter again, thanks. So the way we had approached this process assessment was by starting to develop what we call program impact pathway, which is the schemata that you can see on the screen is an example of a program impact pathway, which actually maps out the intervention components, and it links to each component and what is expected of each of these components and how they ultimately map to the outputs and outcomes. So we mapped this program impact pathway in collaboration with the implementers to basically understand what the implementation is expected to do, how it is expected to roll out. And then we use that to identify and prioritize our research questions. And within the research questions, what are the domains of inquiry? And then based on what our domains of inquiry were, then we looked at what methods fit to the purpose of responding to the questions that we are interested in learning about. So for example, we came up with the questions on how do upstream contextual factors and processes affect the rollout of the intervention. And this could be applicable to any technology integration, but here we are talking about the example of the ICDS CAS. When I say upstream factors, and particularly because we're talking about a digital intervention, procurement processes, setting up of trainings, and what are the facilitators, what are the contextual factors that allowed the digital setup to come together, those are all considered the upstream factors. Then once that is set up, how do the midstream factors and processes affect the use of the intervention? Once the rollout happens, how would the how is it taken up? For example, once the digital integration happens, the procurement happened, all the hardware is available, software is available, the training is done, then what are the factors that will allow the frontline workers to take that intervention up and use it, and for the supervisory cadre and the officials above to use the intervention itself. So that's just and I can go into the details later on in terms of how each of these components were unpacked, but in the interest of time, I'll move on. Could you, next slide, please? Next slide, please. Yeah. So based on the program impact pathway and the questions, we conducted the process assessment and we used mixed methods. We sequenced the data collection based on the rollout of the intervention itself. So we started because we had to observe only after the intervention is rolled out can we observe how it's rolled out, right? So that's how it was set up. And we started with in early late 2016, we did observations of the training. We did interviews with the stakeholders to understand the upstream factors. And then we did a phone survey in August of 2017. And then we did a field survey with face-to-face interviews, surveys with different cadres of workers. Then we also did qualitative interviews with some subset of that sample. Then again, we went back in 2018 to do a full-blown phone survey again with the frontline workers. And then ultimately in 2019, again, we did a bit of a field survey to understand some parts that were not rolled out during this time period of data collection. And throughout this process, we were in touch with the implementers, the tools were developed. It was an iterative process. We developed the tools, shared it with the partners, got their inputs, identified once the findings were there, the preliminary findings were shared. Do this make sense to you? Do they speak to what we have been thinking about? And then planning for the next iteration. So this was quite we did this study in Madhya Pradesh and in Bihar, and we also sequenced how we went about doing this in 2 states, depending on the rollout of it in both states. Next slide, please. So what we found in terms of the rollout of the intervention itself is there was a vision for Digital India at the highest level, which provided an enabling environment for this kind of a digital intervention to be able to integrate into a pilot into a program. And then there was multiple partners came together, collaborated. There was a strong leadership at the highest level to get the buy-in from the states so that it gets the traction within states. And once the program was developed at that level, with the state leadership also mattered in how quickly different states were able to take on the intervention. The state context really mattered in the uptake of the intervention. For example, in Madhya Pradesh, there were already technological capabilities in place because their monitoring and information system was already digitized. So they had existing capabilities of digital infrastructure to quickly respond to take that on. In Bihar, it took a little bit more time because this setup had to be created. So having the right kind of mix of factors facilitated in the rollout. There were certain challenges, and that is to be expected when a new intervention is rolled out. The entire program was based on it was not tweaked to each state specific intervention. For example, there are state-specific programs which usually get into their internal monitoring information systems, but the CAS itself had one common minimum framework, and that was sometimes thought of as a challenge within the state. And then at that time, and actually I have to clarify, at the time of when we were actually looking at this program, the states did not have access to their data, which later on actually got rectified. And then there were certain challenges with the hardware capabilities. When this particular intervention started as pilot in 8 states, it scaled up to, I think, between 500,000 to 600,000 frontline workers were using. So all this would require storage space capabilities when the frontline workers are actually uploading the data. So there were initial concerns that needed to be tweaked and taken care of as the intervention rolled out. Next slide, please. So when that was as if we looked at the upstream factors, and when we come to how the frontline workers themselves were using the app, we started to look at their first from the training perspective. Nearly all the Anganwadi workers in both states, in Madhya Pradesh and in Bihar. Madhya Pradesh is the green bar and orange is Bihar. Sorry, some of the legend is cut out from there. In both states, and when I say all Anganwadi workers, I'm talking about the Anganwadi workers in the sample that we had. It was around 200 in each state. They were trained on, they all said they were trained, they felt comfortable asking questions, they were satisfied with the training. Just about 45% of them felt that they do need refresher training. The training itself was organized in phases. The frontline workers got an opportunity to go back, learn, go back and practice, and then come back and learn more. And there were really some interesting anecdotes when we were in the field observing these trainings. So it was like the way the trainings were organized. They grouped Anganwadi workers into strong and relatively weaker Anganwadi workers from a perspective of technology, integration, use of technology, and then they all ended up learning together. So there, I can talk more about that when we come to the Q&A. Next slide, please. Next slide. Yeah. When we asked the frontline workers about the use of the mobile app itself, they had really positive views about it. They were all using the mobile app. They said they use the app daily, and that daily usage depends on what kind of modules they were using. They more than 90% said they find it easy to use the app. They preferred using the app to using the registers, and more than 90% of them were actually entering the information into the app themselves. I mean, one would think that perhaps they find it challenging to use the smartphones, but when we talk to these ladies, they said they are actually entering the information by themselves. And here is just a quote to illustrate. Earlier, we planned for home visits using the register. Now we get to know from the mobile. Earlier, we needed to explain verbally. Now we show the video on mobile and then we explain. Because of this, it has become easy, and we also update the information immediately. So that's a quote from one Anganwadi worker talking about the app. Of course, there are some challenges reported. Across board, one of the major challenges is internet speed. More than 58% in MP and 46% in Bihar reported slow internet. There were some other issues related to mobile itself, that it stops. It's a slow mobile, or the data are disappearing. They have to travel to different places to actually sync the data. So there are different challenges. But as I had mentioned earlier, we went in phases, and between 2017 and 2018, we have seen that the proportion of Anganwadi workers actually saying that it kind of declined, but there's still aspects that need to be taken care of for any technology-based intervention. Next. Oh, and then I just want to say that there was a health desk that was part of this program. These health desk personnel were critical and the primary support unit for the frontline workers for any technical difficulties. These are the health desk personnel are placed at the block level and at the district level. They would be troubleshooting the problems for the frontline workers. Next slide, please. And when we think about the supervisors, nearly all supervisors again were trained. And when I say all, again, please, this is a sample. They all found it easy to use, but again, there were challenges related to technology, internet, submitting data, or their hardware stopping to work. When we think of the third element, the dashboard, at the time when we were in the field, not all block and district level staff were trained to use the dashboard. And then at the same time, the dashboard versions were being updated. So what was happening was the use of dashboard was limited due to these reasons. Next slide, please. So what do these insights mean for an mHealth intervention rollout, right? So leadership and collaboration are critical, and context matters, where it is getting rolled out and how the context is there. Training, technology infrastructure, and tech support are critical for the start and for continuation of this mHealth intervention. And technology integration can ease program operations, but it operates within the confines of the supply and demand side constraints or factors that affect overarching program factors. So thank you. I would like to stop there and happy to answer any questions. Thanks.
Thank you, Rasmi, for that wonderful overview of not only the evaluation, but overall the intervention itself and how it works and some of the key lessons. And like you said, the devil is in the details. And here we have Sarah with us, who's been very closely involved in working with frontline healthcare workers or community healthcare workers and building tools for them to train themselves as well as to evaluate themselves. And so here we invite Sarah to share about mobile burst learning and job aids. Over to you, Sarah.
Thank you so much for the introduction, and also thank you to OPM for the invitation. It's wonderful to be here today. So my name's Sarah Chamberlain. I'm the director for BBC Media Action in India, the digital director. And BBC Media Action is the international NGO of the BBC. And I'm just going to give you a fairly brief overview of two mobile-based interventions for community health workers in India. One is a learning solution and the other is a job aid. And we've actually been sort of scaling these for the last decade. So about a decade of digital experience on this. So the first is Mobile Academy. Mobile Academy is an interactive voice response, so IVR training course for community health workers. It aims to improve the interpersonal communication skills of the community health workers. So really their counseling skills and their ability to change behavior and to generate demand for public health services. And it's also a refresher of their knowledge on RMNCH practices. And what Mobile Academy does is it offers anytime, anywhere, audio-based learning, which is accessible from any handset and any network via a simple phone call. So you can have the most basic brick phone and you just have to dial a number and listen and press buttons on the handset to interact with it. Next slide, please. So Mobile Academy is one of the largest mobile-based training programs for community health workers in the world. It's been rolled out in 13 states. More than 300,000 frontline health workers have started the course, and more than 200,000 have graduated. It was launched in Bihar in 2012. It was then scaled to Odisha and Uttar Pradesh with NHM between 2013 and 2014. And Mobile Academy was then adopted by the Ministry of Health and Family Welfare and scaled to a total of 13 states. In those 13 states, 40% of all registered ASHAs have started the course. and 27.6% have graduated. And BBC Media Action transitioned Mobile Academy to the Ministry of Health and Family Welfare in April 2019 and exited the program. Next slide, please. So there have been many different evaluations actually over the years of Mobile Academy. So in 2013 in Bihar, there was a cross-sectional study, a small study with 582 ASHAs. And that study indicated that among those who had completed the course, they had significantly higher levels of knowledge about preventative RMNCH behaviors. They also had a lot more confidence about their ability to persuade families to adopt healthy behaviors and to answer their questions effectively and accurately. And they also told us that by completing Mobile Academy, and each ASHA who graduated received a printed certificate from the government, that this really enhanced their standing in the community and beneficiaries' trust, so families' trust in the ASHAs. After we began to scale Mobile Academy, a national version of Mobile Academy with the Ministry of Health and Family Welfare, we did a phone survey, a CACHI survey with 1,600 ASHAs in 6 states. And this found that those who had completed the course were using their new learning to advise new and expecting mothers and their families on how to protect their health and the health of their babies, to inform them about free government services. And they said it was very useful in helping them convince women who previously would not listen to their advice. And this is because, as I said, Mobile Academy is really a tool to improve the interpersonal communication skills of ASHAs, and it equips them with arguments that they can use to persuade families to adopt healthy behaviors. Next slide, please. There's also been a number of qualitative studies. There's a qualitative study conducted in 2018 in 6 states that found that Mobile Academy provided ASHAs with much needed information on family planning methods. And ASHA said that their supervisors, ASHAs and their supervisors both said that family planning is such a sensitive topic and it's a controversial topic. So it's actually not openly discussed at ASHA meetings, and that's often because the supervisor might be male and the ASHAs are women and they feel a little uncomfortable. And they also don't really discuss it with families because it's sort of this taboo subject. So they felt like, you know, Mobile Academy was in the domain of family planning, was giving them really new information. And in other areas, it was filling in information gaps and refreshing their knowledge, making them more confident. And they also said that it was sparking discussion with other ASHAs about the content in the audio lessons in the IVR training course. Next slide, please. And then most recently in 2018, Johns Hopkins conducted a qualitative study in Rajasthan with ASHAs to explore the reactions to Mobile Academy. And Dr. Amnesty Lefebvre, who is on this call, was a co-PI on that study. So what the study found is that ASHAs considered Mobile Academy's content to be a useful knowledge refresher, but they said that the primary benefit was that it modeled a positive communications approach, which inspired them to adopt a much kinder, calmer, and more loving communication style when speaking to beneficiaries. And the conclusion of that study is that ASHAs and higher level health system actors were very positive about integrating future M learning alongside face-to-face training to reinforce, refresh, or deepen understanding. So Mobile Academy is the distance learning tool that we designed. And if you can go to the next slide, please. Mobile Kunchi is a job aid that we developed for ASHAs and Anganwadis initially in Bihar.
Sarah, can I just pause you for a second? So we have a question in the chat. I wonder if you could speak to Mobile Academy and its focus in India. And there was a question as to whether it's been implemented elsewhere globally. And I responded and said I thought it was just focused on India, but of course you've done other work with other ministries. And I just wonder if you could speak to that.
Yeah, absolutely. So Mobile Academy was designed, tested, piloted, scaled, evaluated, all in India. And it's live across 13 states, and it is has been recognized as one of the flagship mHealth interventions of the Ministry of Health and Family Welfare. So, you know, BBC Media Action designed it, and we supported the Ministry of Health in scaling it, and then we transitioned it to the Ministry of Health in 2019. The software that it uses, so it's IVR based, so you don't need any software on the handset, or you just can have the most basic phone and you dial in and that's it. But the software system that sits on the servers that we designed, we've subsequently used to provide training to rural sanitation facilitators with the Ministry of Drinking Water and Sanitation. And so we have actually, during COVID, we launched it on the 10th of August. We've rolled out audio-based IVR training to more than 50,000 rural sanitation facilitators in 9 states. And we're using it right now as part of a pilot with our partner Pradhan to provide marginalized women farmers in self-help groups in Bihar with agricultural training with a very strong gender focus using the exact same technology. Thanks, Amnesty, for the question. And thank you for whoever asked it. So I'll move on to Mobile Kunji then. So Mobile Kunji, keep in mind that we designed this in 2011, you know, which is a long time ago. And at the time, ASHAs only had like the most rudimentary basic phones, and they had actually very low digital literacy levels. And so we designed a job aid that has a print-based deck of cards on a key ring, which you can see pictured on the screen to the left. And at the bottom of every card is a unique mobile short code that the ASHA could dial to play related audio content. So content that was related specifically to the information on the card. And so this is a counseling tool that ASHAs and Anganwadis could use to support their interactions with families. So when they were counseling families. And the cards are color coded. They cover each color coding covers a stage in the 1,000-day window when the most maternal and infant deaths occur. And if we can go to the next slide. Next slide, please. Mobile Kunji went on to become one of the most popular mobile-based job aids for community health workers in the entire world. More than 60 million minutes of counseling content was played by ASHAs and Anganwadis in their counseling sessions or in their interactions with families. And I mean, 60 million minutes of content is a lot of content. More than 500,000 unique mobile numbers called Mobile Kunji, and within Bihar, 144,000 of these were registered CHWs. So it was launched in Bihar. It was then scaled with the National Health Mission to Odisha and Uttar Pradesh. And we finally transitioned it to the government of Bihar in 2019. Next slide, please. So again, there's been many different evaluations of Mobile Kunji. And just recently, a team at Stanford University has published their analysis of 3 survey-based data sets, which compare health-related knowledge, attitudes, and behaviors amongst childbearing women exposed during their visits with CHWs to the deck of cards that I mentioned, and Dr. Anita's voice. Dr. Anita is the sympathetic yet authoritative, engaging, fictional narrator of Mobile Kunji. And so these studies all compared exposed and unexposed, and Stanford analyzed 3 different data sets. Next slide, please. So the results that are in the Stanford publication that has just come out Well, they summarized the results of these 3 different studies based on their secondary data analysis. So the first is Mathematical Policy Research, which was a cross-sectional study in 2014. And this revealed that those who've been exposed to mobile kunji, the deck of cards and the recording, significantly higher odds of consuming iron folic acid tablets, so IFA tablets amongst women, of adopting or taking a set of 3 different measures for delivery preparedness, so preparing for birth, and wonderfully appropriate infant complementary feeding. So the Mathematical Policy study was followed by Care India's annual community-based household surveys. So they did one every year from 2012 to 2017, and these very large surveys. And these surveys also revealed that exposure to mobile kunji, the cards, and Dr. Anita's voice, there were significant improvements in early breastfeeding, exclusive breastfeeding, and again, birth preparedness practices. And then finally, we, BBC Media Action, commissioned our own survey where we saw improvements also in exclusive breastfeeding, as well as CHWs told us, talked about improvements in their relationship with beneficiaries, and beneficiaries talked about how their trust in CHWs had improved and was stronger amongst those who were exposed to mobile kunji. Next slide. So the team at Stanford.
Can you please wind up in a minute?
Yeah, this is my last slide, I think. So the
you.
team at Stanford concluded that significant improvements in RMNCH related knowledge and behaviors were observed for Bihari women who were exposed to mobile kunji and Dr. Anita. And these results can help inform global understanding of how best to use mHealth tools, for whom and in what context. And in the next session, or further on in the session, we'll talk about the challenges that we faced. Thank you very much.
Thank you so much, Sarah. The proof is really in the pudding. We would like to invite Narendra Sinaiji from National Health Mission in state of Chattisgarh to share his perspectives on how digital tools have been useful and his own experience in interacting with different community health workforce in terms of how they use and leverage digital tools for improvement in their own workflows, as well as in monitoring of the routine data. So over to you, Narendraji. Can you please share, and please feel free to speak in whichever language you're comfortable with. We can have translation going. Thank you. Narendraji, could you please unmute yourself?
Hello everyone. Thank you so much, all of you. I'm here about to present grassroots experience related to IT application, mobile application, and monitoring tool related to community level monitoring, related to grassroots level monitoring. First, I would like to mention about the activities related to mobile application and activities related to field and grassroots level. अगर हम बात करें सबसे पहले तो मोबाइल एप्लीकेशन और आईटी एप्लीकेशन में हम चर्चा करेंगे। तो फर्स्टली आईटी एप्लीकेशन का जो पार्ट होता है, आईटी एप्लीकेशन प्रीवियसली डाटा कलेक्शन एंड डाटा गैदरिंग जो पैटर्न होता था वो पेन और पेंसिल मेथड होता था, पेन पेंसिल मेथड, जिसमें रजिस्टर मेंटेन करना, रजिस्टर मेंटेन करने के साथ साथ रजिस्टर्स का डाटा फिर से किसी सेकेंडरी सोर्स के थ्रू हायर सेंटर्स में पहुंचाना, फिर हायर सेंटर में डाटा एनालिसिस, तो ये काफी एक लंबा टाइम टेकिंग प्रोसीजर होता था। लेकिन करेंटली अगर हम बात करें तो करेंटली डाटा मैनेजमेंट में काफी कुछ नई चीजें आती गई और नए नए चीजों का लोगों को इम्पैक्ट मिलता गया। और इन्हीं नई चीजों में सबसे इम्पोर्टेंट अगर हम बात करें तो वो है कंसोलिडेटेड आईटी सॉल्यूशन। कंसोलिडेटेड आईटी सॉल्यूशन में फोकस किया जाए तो जैसे मैं अगर बात करूं आयुष्मान भारत स्कीम, जो आयुष्मान भारत हेल्थ एंड वेलनेस सेंटर योजना है, जिसमें सीपीएससी आईटी एप्लीकेशन यूज होता है। जो सीपीएससी आईटी एप्लीकेशन है वो कंप्लीट फैसिलिटी बेस्ड मॉनिटरिंग सिस्टम होता है, कंप्लीट मॉनिटरिंग सिस्टम होता है, फील्ड लेवल वर्क की मॉनिटरिंग का एक कंसोलिडेटेड पार्ट होता है। तो ये सब चीजें डे बाय डे प्रोग्रेस मोड में आती जा रही हैं, और डे बाय डे अगर हम देखें तो इसका इम्पैक्ट डेफिनेटली फील्ड में इसका इम्पैक्ट दिख रहा है। फील्ड में कैसा इम्पैक्ट है? पहले जिस डाटा को कलेक्ट करने के लिए काफी लंबा टाइम प्रिपरेशन होता था, तो वो डाटा आज एक इजीली एंड वेरी फ्रेंडली मोड में अवेलेबल हो पा रहा है। साथ ही अगर हम बात करें व्हाट आर द बेसिक लॉजिक बिहाइंड दैट, तो नो नथिंग एनी hard type of logic or any big type of logic. That's very simple logic. Central server method. Central server is connecting to all connected devices, and the connected devices are monitored by different channel. If we focus monitoring at country level, if we focus monitoring at state level, monitoring at district level, different monitoring levels. That monitoring level are directly interrelated with each other. If we focus on the central monitor level, in central level monitoring, directly related to state level monitoring directly related to district level monitoring directly related to each and every system, each and every equipment that is used, which have a specific login ID and password. They are directly connected with overall this hierarchical monitoring system. That's very good thing. And secondary, if you focus, yes, sir.
नरेंद्र जी, स्पेसिफिकली कम्युनिटी हेल्थ वर्कर्स का काम में ये डिजिटल टूल्स कैसे यूजफुल होता है, और आपके एक्सपीरियंस में how are they receiving it, how are they benefiting from it? So you have presented from a perspective of overall information architecture and how it is useful for the MIS or HMIS perspective.
Okay.
We would really like to hear from you on the frontline healthcare worker perspective, and how is it really
definitely
from your experience? Thank you.
Basically, I want to start from ground level. Frontline workers, they are mildly trained in IT equipment. Sometimes they are very new for IT equipment, but it's not a big problem. Problem is not able to adapt, but there is no this type of problem, because every type of mitigation method are used to overcome this problem. So how can data gather and how can data added by frontline worker? That is a basic important thing. First, if we focus on the ASHA or Mitanin, ASHA and Mitanin, they are the backbone. In Chattisgarh state, they called as a Mitanin. They are backbone for the health system in community level. In community level, Mitanins are playing major role. Just like they are visiting house to house, they are collecting information related to social demographic and some health related information and some other important information that we want to gather. They note down that in particular document. In comprehensive primary healthcare services, they have a CBAC form, community-based assessment checklist. They have a CBAC form. They just ground level screen that, screen to pupil ground level as need in CBAC. In CBAC, basically few ground level monitoring of NCDs and knowledge TB, leprosy, that all are included in CBAC. And just they ask to some question to particular resident of villages, and they gather information and they come back to facility, and in facility level ANM और community health officer, they are supporting to maintain this data in central server database in NCD application or NCD related portal. They have a that's name of NCD portal, but that's not especially for NCD, but also as CBAC is revised in last year, and that portal is also revised for new disease also. Previously portal is directly basis for the NCD only, but nowadays continuum of care method adapted for the other disease also. That was the data gathering process. After that enter the data that have a follow-up period, and I want to focus this. After gathering this data, every patient have a unique ID. Every patient have a unique ID based on the CBAC and family folder. Family folder is a part of CBAC. CBAC included within family folder, and each family have a one family folder, and if family have a 4 members, in this family folder 4 member CBAC form. That's structure of that data gathering process.
सर ये डाटा कलेक्ट करने में कम्युनिटी हेल्थ वर्कर को कोई दिक्कत होती है, और ऐसे वाली दिक्कत हुआ तो आपने कैसे उसको ओवरकम किया?
डाटा कलेक्ट करने में अगर देखा जाए तो कम्युनिटी हेल्थ वर्कर को प्रॉपर्ली ट्रेनिंग दे दी जाती है, ऑलरेडी उनको प्री ट्रेंड कर दिया जाता है। पहले तो पायलट लेवल में देखा जाता है कि उनके साथ क्या प्रॉब्लम हो सकती है, किस प्रॉब्लम को हमको रोकना है और कैसे हम उसको रोक के हम कम्युनिटी हेल्थ वर्कर को और साउंड कर सकते हैं। तो उसका बेसलाइन पायलटिंग करके इन चीजों को पहले देखा जाता है, और उनकी राउंड टू राउंड ट्रेनिंग्स होती है, जिन ट्रेनिंग में जो प्रॉब्लम फाइंड आउट होती जाती है, हर ट्रेनिंग में उसको प्रॉब्लम को सॉल्व करते हुए अपग्रेडेशन उनको दिया जाता है। मींस दे आर गेटिंग अपग्रेडेशन डे टू डे। बट मेजर थिंग इज दैट इफ यू फोकस CBAC form entry and CBAC form related thing, that's very new thing for those people. So as time to time they already adapted, समय के साथ उन्होंने अडाप्ट कर लिया है चीजों को। और एक जो बात कही जाती है ना, कोई चीज की अगर हम लर्निंग करें तो लर्निंग हमको काफी आगे लेके जाता है। तो डेफिनेटली धीरे धीरे उनके प्रैक्टिस में आ चुका रहता है ये चीज कि हम किस चीज को कैसे किसी मरीज से पूछना है, कैसे उसको किस तरीके से बात करनी है, और किस तरीके से हमें उस डाटा को गैदर करके हमारे आईटी एप्लीकेशन में इनपुट करना है। तो ये जो चीजें होती है ये बहुत इंपॉर्टेंट चीज है। इसमें एक बड़ा अच्छा चीज ये हो सकता है कि फ्यूचर में इस टाइप की एंट्री डिजिटल एप्लीकेशन से, जैसे आपने ऑलरेडी पहले बात की थी कम्युनिटी हेल्थ वर्कर के लिए, तो ऐसा और बेटर हो सकता है कि एक कंपोजिट प्लेटफॉर्म तैयार किया जा सकता है, जिसमें कंपोजिट प्लेटफॉर्म में ओवरऑल डाटा, जैसे हमने तो सिर्फ सीबैक की बात की, उसके अलावा ऐसा भी हो सकता है कि एक कंपोजिट प्लेटफॉर्म में बहुत सारी चीजें एक साथ शामिल रहे, और उन सभी का डाटा इच फैमिली से जब गैदर किया जाए तो एक अच्छा खासा एक हेल्थ रिकॉर्ड हर एक पर्सन का रेडी होगा। और जैसे हम यूनिक आईडी की बात करते हैं, जैसे सीबैक फॉर्म में एंट्री होने के बाद हर एक पर्सन को एक यूनिक आईडी मिलती है, तो यूनिक आईडी का जो मेथोडोलॉजी होता है वो होता है कि हर एक पेशेंट एक यूनिक पेशेंट होता है, और उस यूनिक पेशेंट की यूनिक आईडी होती है। जब वो पेशेंट किसी हायर सेंटर में भी जाता है तो उसी आईडी के थ्रू रिफर होता है। तो हम जो बात करते हैं कंटिन्यूम ऑफ केयर की, तो आईटी एप्लीकेशन के पॉइंट में सबसे अच्छा फोकस करना चाहूंगा ये आईटी एप्लीकेशन में, कि जो कंटिन्यूम ऑफ केयर के लिए भी बेसलाइन लेवल का अप्रोच यहीं से स्टार्ट होता है। बेसलाइन अप्रोच की बात करें
नरेंद्र जी, ये इम्प्लीमेंटेशन में आपको कोई दिक्कत हुआ? जैसे आप बता रहे हो प्लेटफॉर्म इम्प्लीमेंट करने में, और एक तो आपने बताया यूजर लाइक कम्युनिटी हेल्थ वर्कर की उसकी यूज करने में थोड़ा ट्रेनिंग होना चाहिए, और
हमारे
वो ट्रेनिंग के बाद वो हो जाता है, बट टेक्नोलॉजी साइड में से कोई दिक्कत होती है? आपने कुछ फेस किया और कैसे उसको आपने ओवरकम किया?
जैसे मैं बताना चाहूंगा, हम जैसे आयुष्मान भारत हेल्थ एंड वेलनेस सेंटर में कम्युनिटी हेल्थ ऑफिसर्स की पोस्टिंग करते हैं। जो कम्युनिटी हेल्थ ऑफिसर्स एसएससी सब हेल्थ सेंटर लेवल पे पोस्टेड होते हैं, और वहां से वो एसएससी का वर्ग पूरा, वो भी कम्युनिटी लेवल के एक बीएससी नर्सिंग प्लस 6 मंथ सर्टिफिकेट कोर्स इन कम्युनिटी हेल्थ ग्रेजुएट होते हैं, जो कि ग्राउंड लेवल में जाके वर्क करते हैं। तो बेसिकली हाँ, हमने सीपीएससी एप्लीकेशन उनको अडॉप्ट करने दिया हुआ है। तो हमने स्टार्टिंग फेज से ही हमने इस चीज को प्लान करके रखा कि उनकी क्या प्रॉब्लम्स हो सकती है और किस तरीके की प्रॉब्लम उनको ओवरकम करना है। उसके लिए प्रीवियसली हमने इंडक्शन मॉड्यूल जैसा एक ट्रेनिंग प्लान किया कि अगर कोई व्यक्ति एज ए कम्युनिटी हेल्थ ऑफिसर पोस्टेड हो तो एटलीस्ट उसको पता चले कि उसको करना क्या है। आईटी एप्लीकेशन हमने स्पेसिफिक ट्रेनिंग प्लान की कि आईटी एप्लीकेशन कैसे वो यूज करेंगे, कैसे उसको अडॉप्ट करेंगे, उनका पैटर्न क्या होगा, किस तरीके से उसका वो मेंटेनेंस करेंगे, उनकी फ्रीक्वेंसी, रिपोर्टिंग की फ्रीक्वेंसी क्या होगी, रिपोर्टिंग के शेड्यूल्स कैसे होंगे, इन सब चीजों को मॉनिटर करते हुए ऑलरेडी इनका प्री प्लान शेड्यूलेशन ऑलरेडी मेंटेन कर दिया गया। प्लस ये इंपॉर्टेंट चीज इसमें और देखने मिली कि आईटी एप्लीकेशन में सबसे क्रिटिकल पॉइंट होता है, हम यूज तो काफी अच्छा करते हैं लेकिन नेटवर्क की प्रॉब्लम एक बड़ा प्रॉब्लम अगर बात करें तो। दूसरा जो होता है इक्विपमेंट का मेंटेनेंस एक मेजर प्रॉब्लम होता है। कई बार होता है कि स्पेसिफिकेशन का इक्विपमेंट होने के बाद भी इक्विपमेंट जैसे खराब हो रहा है या उसका मेंटेनेंस का और अपग्रेडेशन की कोई इश्यू आती है। ये मेजर स्मॉल इश्यूज होते हैं जो आईटी एप्लीकेशन के रोल आउट में थोड़ा सा एक क्वेश्चन मार्क जैसा क्रिएट करते हैं। लेकिन अगर हम इसको फोकसफुली बात करें इन चीजों में तो रियली ये जो आईटी एप्लीकेशन का हम जो डे टू डे एडवांस स्ट्रक्चर जो देख रहे हैं वो बेसिकली मतलब वन डे प्रोसेस नहीं है, ये डे टू डे प्रोसेस है। ईच डे जो डाटा एंटर होता है, डाटा क्वालिटी होती है, प्लस एप्लीकेशन में क्या प्रॉब्लम आ रहे हैं, एप्लीकेशन में और क्या अपग्रेडेशन किया जा सकता है। तो ये एक रूटीन प्रोसेस होता है, डे टू डे इसमें बेस्ट क्या हो सकता है, उस बेस्ट को करने के लिए हम क्या कर सकते हैं। तो ये चीजें बहुत इंपॉर्टेंट होती है आईटी एप्लीकेशन।
थैंक यू नरेंद्र जी। मैं अभी रैप अप कर लूंगा इस वाले टॉपिक को। और thank you so much. What we learned from Narendra Sinaiji is that there are a number of benefits, and one of the things that he highlighted is that we definitely need to take into consideration whenever we are deploying or implementing such digital solutions, primarily for the community health workers. We need to take into consideration the usability as well as the user training. And we have Sarah with us, who has immense wealth of experience, as you would have noticed from before. I would now invite Sarah to share with us her own experience on how this implementation approaches and some of the challenges to using technology-based solutions to support CHWs are.
Sorry, Uman, before we move to the next session, can I just do a time check? Because we have about 30 minutes remaining. So how maybe you could just recalibrate us and how much time each of the following presentations have, and give a 1-minute warning when you want to move us on.
Sure. No. So
Thanks.
I have quickly wrapped the previous one, and we've also moved into some of the implementation stuff. So
So I don't actually have any slides for this because I thought a discussion would be more interesting. So some of the key challenges that we faced from the perspective of really engaging with ASHAs is low levels of digital skill. And actually, initially, and it's still in quite a few states, low levels of literacy. So although, as we know, it's mandated that ASHAs are supposed to have a 10th pass education, you know, in states such as Bihar and UP in 2012, a substantial percentage of ASHAs, particularly older ASHAs, were illiterate. And the majority of ASHAs had really limited digital skill levels. And keeping in mind that they're sort of older rural women who also, this is something that one must never forget, is your eyesight deteriorates with age. And so many ASHAs, you know, actually struggled with seeing keypads and things like that. So IVR worked incredibly well for ASHAs for this reason. But even just learning IVR in the beginning was a challenge. The other thing that was really interesting and challenging is the gendered dynamics of household phone use in rural India. And what I mean by that is that we assume that people have a one-to-one relationship with their phone because we do. But in fact, the phone that the ASHA was using in her house was also being used by many other family members. And in fact, frequently she was borrowing her husband's phone. And that had real implications for understanding exactly who had taken the course. And we're finding that even now today in 2021, when we're doing this pilot with self-help group federations in Bihar, where we're finding that up to 4 or more people are completing the course on a single phone. So there's one household phone that's being used by multiple people to do this training. And that's fantastic. You know, it's wonderful that, that it's being used so widely, but it makes it extremely difficult to track exactly who's engaging with the service. And you could imagine if you had a smartphone and you were trying to capture data and there were issues around data privacy and protection, having a phone that's a shared household resource has serious implications for data capture and data privacy and protection. And the last thing is that we've experienced throughout all of our mobile interventions, not just for ASHAs, but also for rural women, for beneficiaries, is very high levels of SIM churn. So people change their SIM numbers. What we've seen is they change up to 60% of people change their, or 40% of people change their SIM numbers every 6 months. And we've even seen higher levels of SIM churn than that, and Amnesty can talk to that in the randomized control trial we've recently done in Madhya Pradesh. And so this makes maintaining an up-to-date database of contact details for ASHAs. You're delivering mobile services and you need an up-to-date database. If they're constantly changing their SIMs, this becomes extremely difficult. Thank you.
Thank you. So thank you for that, Sarah. I would like to ask Rasmi to come in and share some of the experiences from and reflections from the evaluation approaches and some challenges around that.
Thank you. So I'll take just a couple of minutes to reflect on the approach. The approach we took was and I'll talk only from the process assessment aspect of it. So this was done primarily to understand the facilitators and barriers to the rollout and take up, but also later on to explain the impact on the outcomes. And this was quite an iterative process. We worked with the implementers. We looked at the rollout of the intervention itself and spaced out our data collection. For example, the implementation was rolled out earlier in Madhya Pradesh compared to Bihar. So how when we did our data collection also, we first went into Madhya Pradesh and then later on to Bihar. And then the other part is it was a collaborative effort with the implementers, sharing the findings, seeing how they fit, are they seeing similar things, and then digging more into, okay, what else do we need to find out more? And using phones, given that this was the frontline workers had already phones, so we used phone surveys also to quickly get information, to feed back to the system on how the training was happening, how the usage was, and what kind of difficulties they were facing. And in terms of the challenges with the technology itself, I think one of the things is technology functions within the context of the program design itself and not necessarily change the design of the program. So it's not a panacea, but it's a tool to help improve the programs that are already there. So I think that's something we should take into consideration when we think about how digital technology can improve service delivery and uptake. In terms of the gendered implications, anecdotally what we found is that the frontline workers were really motivated with the phones, with getting the phones. This was the first, some of them, this was the first time they were actually looking at a smartphone. They started to use other applications looking at news, and even though they could, in addition to using it for the purposes of the app itself. So that acted as a motivator from what we could see. I'll stop there in the interest of time. Thank you.
Thank you. Thank you so much. It's very interesting conversation, but we have to get all the perspectives. And I would like to invite Amnesty to build on our understanding of various interventions that have been shared so far. And could you share some reflections on what works in the context of community health workers, and what are the critical factors relevant to scaling up and sustainability? We still have not seen an Airbnb or a Uber or the likes of that in health apps. And what we really looking forward to give us that secret sauce to make that happen in the context of digital tools. Over to you, Amnesty.
Oh, thank you. No pressure on that. Thank you, Dr. John. So I had sort of planned to kind of go through a framework that a number of us on this call sort of collaborated on, but I'm just wondering, Uman, would you rather I just sort of give, a 2-3 minute overview of this, and do you want to shift to more of a discussion? This
No,
total
go ahead,
talk,
Amnesty. I think,
okay,
no,
sure,
you
sure,
can
sure,
go
sure.
on that, and then we'll take it on from there.
Great, thank you so much. So just sort of in this sort of next section, we collectively wanted a chance, as Dr. John was saying, to draw from the conversation so far and reflect on some of the key factors that may not only drive scale, but also sort of enable sustainability of digital health solutions for frontline health workers. So these factors are kind of derived in part from qualitative interviews of case studies that we conducted in India and South Africa on frontline health worker tools, with a range of key stakeholders, including government officials, academics, researchers, implementers, et cetera. And then as well, it draws from some of the experiences of my co-authors who are listed here on the slide, and include Sarah, Neha Singh from the London School, Carrie Scott, Rajani Ved, Asha George, and of course Purnima Menon from IFPRI. So for those interested, I've given a reference to kind of the overarching paper, which is shortly to come out. We also have different papers coming out from the 2 case studies, so stay tuned for those. Next slide, please. So kind of in this slide, we're sort of trying to illustrate kind of 10 considerations which we think are needed to support the scaling up and sustainability of solutions. These focus on around these sort of 3 sort of wheels, if you will. The first is drivers of equity and innovation. The second is foundations for a digital health ecosystem. And the third is really around elements for systems integration. So I'm going to quickly go through each in turn. Next slide, please. And the next slide. So let's start with drivers of equity and innovation. No, go back one. Thank you. So for this, we've kind of identified 3 factors. The first is to kind of understand who you're missing. And I think this is really the #1 question we get, or sort of misstep we see folks do, is that they really sort of fail to think about who has access to digital tools. And, we've seen a sort of a massive proliferation in access to digital tools, and in particular access to mobile phones. But the social fault lines really sort of continue to inhibit ownership, access, and use of technology. So broadly in South Asia, women are about 28% less likely to own a mobile phone than men. In India, this gap from the last NHFS survey was around 50%. And then amongst those that do own a phone, we see that women tend to have poorer quality phones, including more limited access to smartphones. They also use a smaller range of mobile services and can complete fewer tasks on a phone. So from some of our work in MP, we know that only about 85% of women with access to a phone can actually dial a phone number, and only about 38% of those could open and read a text message. And again, that's in MP, in 4 districts of MP, so it may not be sort of universal, but I think the point is that it remains a big issue. Beyond these factors, barriers to accessibility are more prevalent for women, particularly in terms of affordability and social norms around visiting male-dominated shops for phone top-ups. And all of these factors sort of bear consideration thinking about who programs reach, and more importantly, who they miss and why, including amongst cadres of female community health workers who often are emblematic of these communities. The second consideration is really the need to identify user needs and prioritize those of the end user. So many of you may be familiar with the kind of principles for digital development. There are 9. And while these are great, I think they're a bit limited in terms of actionability. And so we've recommended that 3 questions be considered in weighing the needs of different user populations. The first is, what features have a direct impact on population health? The second is, how feasible will the implementation of these features be? And then how will they benefit the end users of the digital health solution? And then moving to this sort of last point, number 3, we sought to focus on the need to leverage user-led innovations. So this point is really to simply convey that innovation can occur in unanticipated and unintentional ways, which can provide added value. So to give a quick example of this, actually from the project Rashmi mentioned, this is from some of the work she and her colleagues did on ICDS-CAS, where they found that as part of the program, ANMs were, Anganwadi workers were provided not only with a mobile handset and the app, but as well data and unrestricted downloads of other applications on that handset. And this flexibility enabled health workers to download WhatsApp and use it along with voice calls in parallel to ICDS-CAS. And they then could communicate with supervisors, other frontline health workers, and their beneficiaries, and basically provide enhanced services. And that proved particularly critical during COVID. And hopefully Rashmi can tell us a little bit more about that during our Q&A. But if I move next to the next slide and to our second wheel, if we now move, you'll see here we've got kind of 2 additional points, and that is as part of efforts to design for digital ecosystems, digital health solutions need to be designed for evolving needs. So they should be flexible and adaptable, balance issues around configurability with customizability. And just to draw from, Sarah's example from Mobile Academy, she mentioned that this is a training course that had also been redesigned for the Department of Drinking Water and Sanitation. And they created an additional training platform, which basically is able to run multiple courses of configurable length at the same time, which is pretty amazing. For the NCD app as well, which we heard a little bit about, that similarly has been configured to include additional modules. For example, there's one on cervical cancer screening, and that's a feature that can be turned off or on depending on the local needs, which I think is pretty important. The second point, number 5 here on the slide, is that we really need to move away from siloed monolithic architecture and invest in interoperability. And I don't need to say a lot about this, Uman, I'll let you, really you're the best person to speak to this, but just I'll underscore this point by saying that a national digital health architecture that enables diverse applications to utilize common resources, including national data registries, is really needed in India and elsewhere globally. So the next slide, please. For this last point, we really just wanted to say that, make the point that supporting data governance is really essential. So in India, while legislation has been proposed, it has yet to be enacted. So understanding that the future really must favor the protection of patient rights and privacy, digital systems have to be designed in accordance with best practice from the outset, even if the legislation necessarily hasn't been enacted or regulatory bodies yet exist to kind of enforce them. So we've broadly sort of seen that this is really critical for avoiding costly retrofitting, obviously protecting the rights of and privacy of individuals, and really kind of ensuring that valuable data are not mined by organizations that don't have authorized access. Next slide. So I want to move quickly through these last points just so that we can hear from you guys. Next slide. So this first point is really that programs need a long-term vision for implementation support. This should be articulated from the outset and include specified roles and responsibilities over time for key stakeholders, along with the capability and resources required to manage, maintain, and support the solution after scale up. So I think this is really a sort of a critical factor for just thinking about not just how do I scale the solution, but how do I ensure that it's embedded within the DNA and the routine functioning of the health system. The second point here is really around government funding for solutions in the public sector. So I wish I knew what the magic formula is for securing this, but what we've seen is that designated government funding is really essential to sustaining implementation. And the pathway for this is perhaps a bit opaque for some solutions. And often we'd have to say some degree of continued external funding may be essential, if not essential, particularly helpful, because it adds a degree of added flexibility, particularly around issues on procurement, perhaps, and doing additional testing and innovation. However, for full-time sustainability, financing for all aspects of the digital health solutions really needs at some point to come from and be integrated into routine health systems budgets. For our next slide, please. For this kind of final slide, I wanted to emphasize 2 additional factors. The first is really sort of around evidence generation, and this sort of builds on some of what Rashmi was saying earlier. And we really kind of have to define what evidence matters and to whom from the outset. So often kind of the perceived trajectory of a successful public health intervention in other domains is through this kind of pathway of first demonstrating efficacy and then effectiveness, and then you scale up. The technology spaces really deviates from that model and often instead focuses on kind of iteration and learning while doing. Unfortunately, this has often left major gaps at a global level in terms of evidence generation and knowing what works. At a country level, we've seen that sort of whether evidence is captured and how can vary quite a lot. So I'm based here in South Africa, and what we've seen for a lot of the national digital health solutions that the ministry has scaled is that the absence of impact level evidence linked to direct health outcomes has been a major impediment to sustainability, in part because the Treasury, so to secure government funding, it requires that you have both impact and cost effectiveness evidence in your case. Otherwise, you can't get Treasury funding. And unfortunately, in scaling up a lot of solutions, there's sort of been a degree of short-sightedness, I would argue, perhaps controversially, and those two critical factors have been omitted. And what that in essence means is that programs potentially, their sustainability is impeded because we don't have that. So for in India, let's hear from our other panelists as to what they think about the value of evidence. We'll come back to that. But the last point here, and perhaps this is, we've saved the best for last, but we found that champions are really critical to scaling up and sustaining digital health solutions. So I'll leave Rashmi to come in and talk about ICDS CAS, but for particular solutions, you might see one particular person within, a Ministry of Health that really, or at a state level that is really, takes a particular solution on board and drives its scale up. The challenge with that is, while it's great to scaling up, the reality is that often officials might move positions, retire, or be transferred. And so too can sort of questions about who has ownership over that program be after they leave. So ideally, to ensure sustainability, the ownership of a digital health solution has to evolve and ultimately become agnostic to identified persons or organization, and the value to the health system continuously renegotiated as part of kind of a continuous relationship building. So those are the 10 points. I'm sorry to have left just a little bit of time for discussion, but I look forward to hearing what others think about this. Over to you, Oman.
Thank you, Amnesty. That's a brilliant overview. I wish we had another 2 hours to go through each of these, but I think we have some interesting questions as well. So I would invite some of these questions to be answered live. So here is a question on, does digital enablement of community health workers help improve the continuum of care for women? And this is directed to Sarah. Your data shows improvement, some indicators, but not all. So Sarah, would you want to take this question? You can answer live if you want.
Sure. That's a really, really burning question, actually, that we've been considering as well. And we've been actually thinking about this in the context of our direct to beneficiary digital communications, where it's very evident that behaviors that are influenced by very powerful social norms are very tricky to shift with direct to beneficiary communication, and that the frontline health worker, the community health workers' sustained face-to-face engagement is absolutely critical to shifting those kind of practices. And the question was about, well, why did we see some behaviors shift and others not with exposure to mobile kunji? I mean, I think, again, it's how sustained is the use, because the frontline health worker is carrying a tool, and she chooses it to use it in circumstances and not in others. And she, what we saw is that the frontline health workers mainly used a small subset of the 41 different cards and audio files that they could have used. So, they self-select areas that they think they should focus on. And so, that is a bias or a weakness in the communications. And by the way, we use call centers actually very effectively to encourage them to use a wider range of cards and a wider range of audio content in line with the National Health Mission's annual calendar of communications in the state. And that really helped broaden the range of communications that the ASHAs were undertaking. I hope that helps.
Thank you, Shara. So there is a question on the role of implementation partners, development agencies, as well as multilateral agencies, including donors, in how to support the digital health tools in the context of community health workers. I would request both from a perspective of an implementer from Narendra ji, as somebody who has been managing this program at the state level. So what do you see is the role of implementation partners and both donor agencies as well as other agencies in terms of providing a supportive infrastructure, as well as do you think there is a role, and how can we go about that?
Yeah, thank you so much, sir. Definitely, we can say development partners are playing a role in implementation of that IT platform or IT application. If we focus for the community health worker perspective, state specific have a on development partners as per support method or support need. Just like in state health resource center is working for community health workers. That means they are controlling, managing, training, overall activity they are doing by state health resource center in Chattisgarh state. Different state have a different structure. Some state have a other development partners, and some state have a for specific activity they adapted a different development partner. And in level of knowledge sharing, in level of new technology intervention, they are playing very good role in terms of new technological intervention. They introduce new technology and they helpful for the rollout this type of activity in specific activity role of specific development most important. Just like a NCD application Tata Trust is providing support to Chattisgarh in NCD application rollout. They have a specific structure for monitoring to district and troubleshooting and other supporting hand-holding support related activity. So development partners are a very important component in health system, and definitely they bring new change and new era for the digitalization and digitalization day-to-day advancement in digitalization.
Thank you so much, Dr. Narendra ji.
Thank you.
Amnesty and Rasmi, this question is to both of you. So from a perspective of an evaluator, how do you see the, I'm trying to combine two questions. One is the role of development partners, funding agencies in the context of scale up, as well as bringing about innovation. Two is that there is another question that asks does the novelty factor kind of ignore the need for broader systems level intervention, systems level reforms that are fundamentally kind of challenging the delivery of optimal health services, particularly at the community health workforce, because digital sounds very fancy and everybody likes to do an app. And so both from your perspective, Amnesty, as well as from your perspective, Rasmi, from what you have found in your evaluation and broader evidence, if you could allude to that. Thank you.
Rashmi, do you want to start or should I?
Please go ahead, Amnesty. I think particularly the first part of the question, you had raised it in your presentation on the role of fundability. Yeah, please go ahead.
Yeah, I mean, look, sorry. I mean, maybe as an evaluator, we're trained to be a little cynical, but I think, look, I do think, maybe Rashmi, you said this. I think technology at times is really just putting a Band-Aid over large health systems problems. And I think, often there's, you know, reluctance to address those larger systems problems, and there's not funding to do that. And you can often convince, I mean, if we look at sort of who's funding digital health solutions, it's 90+% of the time it's going to be external donors. And would you realistically get those same donors to give that same amount of money and investment to, you know, addressing the broader health systems challenges? Probably not, just because it's not necessarily sexy or interesting. And but maybe that's a cynical sort of glass half empty perspective, and Rashmi is a positive, glowing alternative viewpoint for me. What do you think, Rashmi?
Yeah, let me. I agree with you. I do have this cynical perspective, but I think the positive part of it is how do we make. I think that's what I was talking about earlier. We cannot think of technology as a panacea. It is not going to fix the problems of the program design at large. The technology comes and tweaks and improves the efficiencies within a program design.
It may.
All right.
I mean, and I think
cautiously, it may. I mean, I'm thinking about the frontline workers. You give them a digital tool. Instead of the frontline worker actually sitting and filling all these 10 registers, if the tool makes it easier, digitizes her work and helps her, that's great, right? As a job aid,
for sure. But if it's a duplicate of a register, well, yes, you know, but you know what I mean. So yeah, go ahead.
Yeah, but and the intent is to replace the registers with the technology, right? If you duplicate, so in the best case scenario, it will work, but it won't change the quality of the data that the frontline worker enters into the register. So that part is not, that's not a system.
It may improve quality. It may improve quality at different levels because you have less people hand aggregating data, you know. So on that level, it could, and it could improve the timeliness of the data that one receives. And but I think it does also open up a whole host of other challenges around, now suddenly you have patient level data where previously, you know, at upper levels of the health system, you would have more aggregate data. And that raises in lots of questions around, is it ever possible to truly anonymize the data captured on these digital tools? And then, you know, that data raises lots of, you know, there's a monetary value. So it then brings in all these issues on privacy, governance, ethics, et cetera, that perhaps were not there in a pre-digital era in the same way. But over to you.
But I wouldn't want to we have to put in those safeguards, right? I mean, right now, for example, I mean, the cynic part of me, right? Even when you and I are using the WhatsApp, it seems like Facebook is going to take all our data and sell it off. So I don't need to talk about here we are talking about the patient level data, which is even more needs to be protected.
Yes.
But I think how do we make frontline workers work easy by placing the safeguards? Let's not throw the baby with the bathwater, right? Let's not say because we cannot protect, don't think about digital technology. And at the same time, don't think of digital technology as changing the game of the system completely, that suddenly the coverage of interventions is going to improve. And this comes back to the one question that came up around, will technology improve continuum of women's access to continuum of care? That again depends, and I'm talking more from India perspective, where two different ministries deliver this set of interventions along the continuum of care. Now, the technology will facilitate that if these two systems integrate and deliver. So the technology in silos probably will not help change the access to intervention.
Correct.
So I mean, there are a whole different
I think that the whole issue of really needing an overarching, you know, enterprise architecture, which allows multiple applications to contribute data, would help fulfill this vision of a, you know, electronic medical record, avoiding duplication, all of that, and potentially allow us to get to a place where you could then be looking at, you know, addressing gaps when people fall out of services, you know, and unfortunately, we're a little bit further away from that, realizing that vision, you know, than I would like us to be, and then we necessarily need to be if politics and other things were removed.
And this brings us back to the need for systematic documentation from the outset. and actually piloting and testing it in a small scale with full evaluation built in,
See,
and
this
then
is where
scaling it up.
No, see, this is where you and I disagree, because I actually think that model of a small scale pilot, and that we're very comfortable with when we test a drug or when we test a vaccine, isn't something that's going to work for technology interventions. That if you don't basically have from day one and this is where Sarah, I hope, will come in with an opinion. If you don't have from day one the right people on board that can actually take you to scale, and a vision from day one to go to scale and the resources to follow that trajectory, I can't think of any digital solutions really offhand. I'm sure there are a few examples that have actually followed the trajectory of very small scales. I mean, if I look, Kunji and Mobile Academy were done in Bihar first, and they, at least in the case of Mobile Academy, it did scale. But by and large, most solutions that scale were designed bespoke for scale from the outset. Maybe I'm wrong.
Just to add to that if you don't evaluate at scale, you are most likely going to be evaluating something that is dependent on donor dollars and has way more resources than a state or national government will be able to sustain once it's at scale. And so the impact that you're able to measure is likely to be much more significant then once all the compromises of scaling something with a public health system that has limited people, with limited resources, with limited training and vast populations. So unless things are evaluated at scale, you're just not getting it, you're not identifying the challenges really either. And that's why I loved your process evaluation. Because I know that was done at scale, and it's so important to do those kind of process evaluations in addition to impact evaluations.
But
after
it also
things are being run by the government.
But I also think it doesn't mean that what you're talking about the need to really refine what it is you're scaling, that it doesn't mean that you can't do both. I mean, I actually think you can do minor micro experiments within, a larger effort to scale something up, to hone it, to iterate, to refine it, et cetera. But I think all of the resources, who you need on board politically to sort of move things forward have to be there from the outset. Otherwise, it's a bit of a futile process.
No, I completely agree with you.
Yeah.
When I say pilot, I'm not talking about lab kind of a setting. But even a scale doesn't have to be giving it to all the frontline workers across the country, right? That doesn't have to happen.
Sure.
Testing it.
Sure.
It could be.
When we talk about
sorry, I think
when we talk so see, when we talk about scale, we should not limit it to just implementation. Scale is also on the enterprise side. Most often what happens is that you build an enterprise architecture only for a district. Then if you try to roll it to the state, technology will not support you at all. So you build for scale, but you can stage wise you can implement, and because both the technology as well as the human factors need to go hand in hand. Quite often we tend to think that it is that the frontline healthcare workers are not up to speed with it. If they have a lot of challenges in actually using those tools because of this limiting factors, because of architectural issues or network issues, or because they are using outdated devices, we can't necessarily blame them alone, in the sense that, not blaming, but it needs to be seen much more comprehensively. I think we have really had an interesting session. Sometime we could not cover many of the questions that came in. We will try to address them later on one-on-one. We have taken note of all the questions. So what we really learned today is that, yes, we definitely need to have a framework, a lens through which we see, and the most important part is there evidence for whatever we are doing? Is it backed by sound science? And two, how is the adoption of that on the ground by frontline healthcare workers or community health workers? And is it really helping them improve the delivery on the ground? Because at the end of the day, like we all know, it is these are really valuable tools in the hands of frontline healthcare workers or community health workers, and our tools should be to improve workflows for them, enable them to use the data that they are collecting to make decisions closer to where they're delivering care, but not driven from some office 3-4 levels up the ladder. And that Narendra ji also pointed that out, how important it is for these information system to actually inform the program itself and how that can be improved. Thank you so much for this time to all the panelists. I will hand over to the organizing team.
Thank you, Uman.
Thank you, everybody. I would like to extend a heartfelt thanks to all the panelists and the attendees. We look forward for the next session coming up next month.